What we're going to do this year, just like we did last year, is a reminder that a new year doesn't mean a new treatment plan. For years, dealing with post-payment cases, I always found it odd that, as did payers, which it prompted post-payment analysis, is that, a new year, new benefits, new number of visits, and all of a sudden, patients start into a medically necessary course of care on or immediately after the first of the year because of the new benefits, and they get more visits. Well, what you have to remember is that those visits have to be medically necessary. And while there may be a visit limit in terms of the benefit, where they get 12 or 20, and the best way to think about it is they get up to 12 or 20 or 50 or a million, whatever the number is. But don't forget, they only get those visits if they're medically necessary. And medical necessity to an insurance company means a whole lot, is defined a whole lot differently than it is from a clinical perspective. So you have to be very, very, very cautious, when starting out a new year. My rule is you look for a mechanism of trauma. It's got to be a significant health problem requiring, where you don't have to convince the patient to come 3 times a week. They're coming because they're hurting. So the, slept funny on the couch, aggressive feather dusting, long car rides, that kind of stuff. I mean, not really going to move an auditor on the other side of the fence that's a significant injury and a significant health problem. And you'll know. I mean, your patients. The patients that are going to come in episodically for 1 or 2 visits and they're gone. You really can't write a treatment plan around that. And those visits would be non-covered, in which case you would charge the patient cash with advance notice consistent with whatever the notice requirements are in your contract with that payer. So it's fine, to mix, you have an insurance and a cash practice. I think a cash practice is a whole lot safer, and certainly can be a lot more profitable. But if you are going to dip your toes in the insurance world, be very, very careful. Watch for, all your patients are starting new plans of care in January. It's really noticeable, to payers, because they'll see that, maybe you switch the patient, they ran out of visits in April, and then for the end of the year, there's nothing, and then January 1, boom. And if you do put somebody back into billing after the first of the year, make sure there's a definable mechanism of injury. That's the one thing that you do not want to leave blank on your history of present illness. Location, quality, severity, duration, timing, all that stuff is important, but context or mechanism of injury is critical, because you need to demonstrate that there was a predicate event that caused the need for this treatment. And even if you're in and out in like 3 to 5 visits, fine, but don't do hey, you get 12 visits, there's 12 months in the year, how convenient, because that's also noticeable, and it's usually identified as maintenance care, and it'll get you audited. And again, just because a patient has a bucket of visits doesn't mean necessarily that you have the juice to bill them. It's all about what that carrier's policies are. Sometimes their medical necessity is predicated not only on clinical facts, but also on the documentation. So be sure to read those policies very well. Same thing with Medicare, especially with Medicare. I mean, in Medicare cases, if your documentation isn't perfect, and it's very, very time-consuming to make it that way, and I have provided examples to clients that have been involved in Medicare cases, and unilaterally it has driven them out of the Medicare billing business, and they treat their Medicare patients for cash. And maybe, later on in the year, we can have that discussion. We've had it in the past, but for those that didn't hear it, it can be done, and it can be done compliantly, consistent with the requirements of the Social Security Act once you understand them. To close up, this isn't a very deep topic, but if you are going to start a patient on a new plan of care, no matter what time of year, maybe they've got 20 visits and you're going to use 6 here, and then later in the year you're going to use 5 or 8 more, that's fine. But just remember, when, even if it's a condition that you've seen them before, when you're starting a plan of care, it's got to start with a plan, which means you got to do a history, an examination, a diagnosis, treatment orders, plan of care, and specific and hopefully objective measurable goals that you establish as the basis for how you're going to evaluate when the patient's done. It's a lot of work. Unfortunately, I'm not in a position to recommend any EMR program because they're good on recording findings, but they kind of lack the ability to build these objective measurable goals for subsequent visit analysis, and that's why most of them fall short in this when you're doing it. Some of them can be customized in this fashion with a bit of work, but it's not an easy process once you understand what it is that payers are looking for. But even if you get close, keep your visit schedules 2 to 3 visits a week if you're billing. Avoid, as we talked about last time, some of these very highly audited code pairs, manipulation and manual therapy or massage. Delegation of massage is a big issue around the country these days. Billing for 3 to 4 region spinal manipulation plus an extremity, maybe plus manual therapy. That would be the trifecta that'll get you a lot of attention in the post-payment realm. And keep your visit schedules tight, duration of care reasonably tight. Get in, do your thing, and get out. And if you can avoid, always doing the same codes every visit, and always avoid, let's say every patient you're going to do 6 visits and your diagnoses are the same, the codes are the same. That's also very identifiable to their data analytics computers that decide who they're going to audit. So at the end of the day, just remember, it's a new year. Happy New Year. And patients are going to say, hey, I got 20 new visits. And yeah, they do, but they have to be medically necessary. And you, unfortunately, have to be the one to tell the patient the truth about whether their condition requires that type of care, whether they're committed to following through and letting you do that. Because interestingly enough, you can order 3 times a week care and a patient doesn't show up for it. What does that mean in terms of your expectation? It means that you're not going to achieve your goals. It also means that the patient probably really didn't need the amount of care that you prescribed. And your need versus their need, 2 different things, I get it. But to a payer, they would use that as evidence that the patient's condition wasn't that bad and they didn't really need the care and none of it was medically necessary. So those are some of the traps. But because it's a new year, I think it's important to recognize that new plans of care that you start in January always get looked at, especially when the patient's been out of care for a while because they ran out of visits. So just be cautious. Yes, you can dip into that well, but understand there are pretty significant documentation planning and treatment planning rules that allow you to do it, because I certainly don't want to see you as a post-payment client while we're trying to argue over medical necessity issues. That's all we have for this week. Unfortunately, I don't know who's following me because the schedule hasn't been set up yet, but I look forward to seeing you in February. Everybody have a great new year.